The skin is our body's largest and most visible organ. It serves as a shield, a first line of defense against the outside world. This integumentary system does far more than cover our bones and muscles. Epidermis, dermis, and subcutaneous tissue. It keeps essential fluids in and harmful microbes out. It regulates temperature by sweating and adjusting blood flow. It houses nerves for touch, pressure, pain, and temperature. When that barrier is compromised, the body is vulnerable and infection risk rises. A major burn or wound is systemic. Pain, swelling, and the healing process can cause stiffness, weakness, and loss of independence. Your goals are threefold: safety, support healing, and restore function. Wound care fundamentals are core PT skills. You become a key part of the team with a simple framework to build confidence and improve care. A burn is an injury to skin or other tissues caused by thermal heat, radiation, chemicals, electricity, or friction. Severity is about size, but more critically, depth. Classification guides dressing selection, exercise timing, and realistic goals. Superficial burns affect only the epidermis. Red, dry, painful, no blisters, healing in 3 to 7 days without scarring. PT role: education, pain relief, and protection. Partial thickness involves epidermis and dermis, superficial or deep. Superficial partial: redness, swelling, clear fluid blisters. Very painful. Deep partial extends further, may be less painful if nerves are damaged. Higher risk of scarring, more intensive care. Full thickness destroys epidermis, dermis, and may reach fat, muscle, or bone. Appears white, leathery, charred, or dark, often insensate centrally. Requires surgery, often grafting. Expect significant scarring, high contracture risk, and functional limitation. Healing unfolds in 4 overlapping stages. Knowing the stage guides safe, effective PT decisions. Hemostasis begins immediately. Vessels constrict, platelets plug, fibrin mesh seals the wound. Inflammation lasts days. Redness, warmth, swelling as neutrophils and macrophages clear bacteria and debris. Proliferation builds tissue. Fibroblasts deposit collagen, new vessels form, granulation appears, epithelium migrates to close the wound. New tissue is fragile and needs protection. Work with, not against, biology to achieve the best outcomes. Pressure injuries are localized damage over bony prominences from pressure and shear. NPIAP staging standardizes communication and planning. Stages 1 to 4 plus unstageable and deep tissue pressure injury. Stage 1. Intact skin with non-blanchable erythema. On darker tones, look for color change, temperature, or firmness. Act early with aggressive pressure-relieving strategies and education. Stage 2. Partial thickness with exposed dermis. Pink-red, moist. May have a serum-filled blister. Stage 3. Full thickness with visible fat, granulation and rolled edges are common. Stage 4. Full thickness with exposed or palpable deeper structures. Unstageable. Depth hidden by slow or eschar. Deep tissue injury. Persistent deep red, maroon, or purple discoloration. Accurate staging drives documentation and advocacy for care. Choose dressings based on location, size, depth, drainage, and infection. Goals: protect, maintain moisture, manage exudate, and provide comfort. Gauze: versatile for cleaning, packing, and covering, but can dry out and adhere, causing trauma. Transparent films are vapor permeable, yet waterproof, ideal for securing dressings or superficial wounds. Hydrocolloids create a moist environment and gel with low-moderate drainage. Foams are highly absorbent, insulating, and cushion wounds with moderate heavy exudate. Alginates, derived from seaweed, turn to gel and are ideal for packing heavy drainage. Hydrogels donate moisture, promote autolytic debridement, and reduce pain for dry or minimally draining wounds. Antimicrobial dressings, silver, iodine, or honey, help manage infection risk. Use should be guided by the clinical team. Your work starts at admission and continues long after closure. Positioning counters the posture of comfort to maintain tissue length and prevent contracture. Splints. Pillows, specific postures. Scar tissue is less elastic, lacks sweat glands and hair, and tends to tighten. Begin scar massage once closed and stable to improve mobility. Teach stretching and ROM to prevent joint limitation. Compression garments can help flatten and soften scars. Combat deconditioning with graded activity. Start simple. Progress to walking and functional tasks. Adapt for pain, dressings, and equipment. Practice meticulous hygiene and educate patients and families. Know when to proceed and when to stop and seek help. Worsening infection signs. Increased redness, a red streak, new swelling, warmth. More drainage, yellow-green milky color, or a new foul odor. Systemic signs. A sudden pain spike, fever or chills. Dark, black, or excessively pale edges can signal ischemia. Sudden wound breakdown or new functional loss warrants escalation. Checklist. Assess wound and dressing. Size, depth, drainage, color, odor. Is it clean, dry, and intact? Consider healing stage to set intensity. Always protect fragile tissues, especially new grafts. Position well, educate at every opportunity, and communicate all changes.